What's up, project people? You're back with Blake, and this is new intro.
I can't bounce off that kind of energy.
Yeah, the intro is really awkward though. I don't
is.
like to do the
It's
intro.
more awkward when you do that.
Yeah, or I'll be like, "Hey, legends." I'm just sick of hearing it because I always say that.
Medigen.
Yeah.
Medigen.
Yeah, whatever. Just because I got a lisp. Anyway.
I just thought of my high for the week.
Yeah, sweet. Well, welcome back, everybody. I hope you're all, doing really well. That's the other thing I say quite a lot. Hope you're all doing well. But I actually mean it this time. Otherwise, I really
Usually
do hope...
Usually I hope you're all
I
doing
hope that
terribly.
if you're listening to this podcast, I'm looking into the mic right now. I hope you are having a good day. And I hope this podcast is going to make you laugh, feel things you've never felt before, and really learn. I
don't think we've ever recorded a podcast after a day of work, and this is how mushy our brains must get at the end of the day.
I love this podcast, and I was explaining to you before this. I mean, I love all our podcasts that we do, but I was saying that one of the things I got from this podcast, it was such a reflection moment, because as a clinician, you go through these iterations of student, new graduate, 3 years, 5 years, 10 years, 15, 20, and so forth. And you kind of have these points where you look back and think, oh, wow, that's how far I've come, or this is what I know now, and it's really nice. So thinking back to Ian Griffiths, who was our guest on today for part one, I see him somewhat as a social media mentor, someone I've followed for years and years, and I've really loved his stuff and his ideas, and I've never seen him say something wrong, really. Like, he's always so nuanced to it, like, oh, it depends, or this or that, and he's never black or white, which is great, and I think I get a lot of that from him. And yeah, seeing him somewhat as a mentor without him actually knowing it, but he probably got that vibe because I asked him every single question on earth. And yeah, it made me think how important mentors are as anyone in life, whether it be student, new graduate, or whoever. And I think he was a bit of a social media mentor. My current mentor and probably first mentor, Justin Smith, how much I learn and get called out and make me think and be a better clinician. And still making me better at this stage, and hopefully a lifelong mentor, because he mentioned his mentor, Simon Spooner, did he say? Simon Spooner? Yeah.
Or a colleague.
Yeah, a colleague, and now he's a peer. And I think of that similar with Justin, all the things I've learned, and if I didn't have that, where I would be. I mean, do you have anyone like that you kind of... I mean, obviously me is one, but anyone else?
As a mentor as me clinically?
Yeah, just and everything though, like not just clinically, but kind of life, because it all kind of twines together. I mean... And I think of the example, learning how to communicate better with patients, which you learn from your mentor, helps you communicate better with people outside of work.
Yeah, I mean, definitely Dave Renfrew. I learn a lot from him.
Yep.
The other person I would say would be Nikki Manville. We run together all the time, and now spend the entire weekend at the beach together. So we're always talking about life and relationships and physio stuff.
How you hate your partners.
No. How our partners are too much overachievers.
Yeah. Josh, if you listen to this podcast, you and I better catch up and talk about the girls.
No, but I would say, like, Nikki's definitely my mentor, physio-wise, but also just a good friend as well, and life-wise.
And it just made me think how much you owe them, because they've really, and I just think of, and this is not my own personal experience, I don't know if anyone else has gone through that, but you continue to always learn and be better, and you think without those people where you would be. And even there's no way that I would have started this podcast, there's no way I would have felt confident explaining these things, and even confident being wrong, without people like Justin and people like Ian and other people. Yeah.
Nikki was my placement supervisor when I was in a fourth year. That was when I first met her, and I feel like she really made an influence on my ideas around physio at that point in time.
Yeah.
And then,
I'd say, like, Justin was my second year, and it was just this, like, instilled this weird thing that I'd never had anyone talk about it that way, and I was like, this is incredible, like, and then it just went from there. And he told this story off air about, and I'm not going to mention who it was, but he told this story about him looking up to someone, and they were a really prominent person, and then later on presenting alongside them at a conference, and the reflection point for him, and I was like, wow, I feel like I'm going through that right now. But he's a lovely guy.
I don't think we talk about that on air. I think that was after we stopped.
Oh, yeah. Oh, that was the other thing. So get this. So we're doing it 9 a.m. Sunday. He's on the other side of the UK at 10 p.m. Saturday night, and we got to an hour, and we paused, like, great, mate, thank you so much for coming on at this time.
He was like falling asleep.
Yeah, or he was energetic, but I was like, you got to let him get back to his life and go to bed. And we talked for another hour.
Yeah, we should have kept playing.
I know. I was like, it was so incredible to see, because we're passionate health professionals, and I'm so passionate about podiatry, and to see someone else so passionate about podiatry, I was like, this is awesome. I could talk to you for years.
And just a cool guy. Yeah, like easy conversation.
Yeah, it was good. But let's quickly get to any highs and lows before we jump into part one. Have you got any?
My high happened just this afternoon. I was treating one of my runners who has had persistent medial tibial stress syndrome since 2019. Seen a bunch of different health professionals, tried many different things, various shoes, all this stuff. Could not get away from this bilateral MTSS. And saw him today after like 3 sessions of a gradual return to running program and some strength stuff, and he's getting better, and he's running,
good.
And it was so exciting.
I
was very keen for him. Yeah.
And the goal was to get back to running.
Yeah, he just wants to run. He just froths it like us.
Yeah, it's and you can never experience it. Can you just imagine you haven't been able to do something for so long, and then you're the person to help somebody get back to that? And obviously,
and he was saying, he was like, I've had to in the last 3 years, delete all of my all the running off my social media, because it would make me so sad because I wasn't able to run, and I kept trying all these things and I just couldn't get there. And
that's what it's about.
Yeah,
that's what it's about.
Big high. I was very
Man, we shouldn't be recording this late. I'm bloody pumped for you. That's so exciting.
Your hour.
Yeah. So I am a bit of a live because we talked about this last time. You're an early bird. I'm a night owl. Yeah. Any lows, or life can't get low at this stage because you're running? You did the biggest week ever on record, 62.
5.
I
wasn't the biggest on record, but of recent times, yes.
Yeah.
That was 2 weeks ago, though.
Yeah.
No lows.
No lows.
No, I don't think so.
Righto. High life.
Oh, I know. Our macros discount code doesn't work anymore.
Oh, yeah.
Now we have to pay full price instead
of... Yeah, but I see some odd people that have only got like a couple thousand followers, and Macros sponsors them. So
maybe we should start tagging them.
Yeah, if you're the CEO of Macros and you're listening to this physio podcast, physio podiatrist podcast, please give us a discount, and it needs to be better than 50% off, because that's what we were on.
Maybe for free if you could.
Yeah, I'll promote it, even if I don't believe in it. I'll fade.
No, ethically. We love it. We eat this thing every night.
I'll start giving it to patients, tell them it cures their heel pain if you give me free Macros. I'm ready to do some ethical fading.
This is meal delivery for those of you who don't know what we're talking about.
Yeah.
Not sponsored, but
no lows, no highs. Cool.
You?
Yeah. Couple of lows, lots of lows, no highs. No, it was a bit of a mix. The high was... We did 6 hours of podcasting on the weekend, and it was freaking awesome. I was full of energy. And after we did the podcast with Reg from the Flyers, I had to do a 30k long run, which was Sunday night. And I was pumped up because we talked to Ian, we did the talk to the Foot Collective, talked to Reg, and we'll talk about running. And I'm just driving to the Fernley going, I'm pumped, hey. I'm going to run the longest run I've ever done ever. I was going to go like 35 or something like that. I only had 30 planned. Running, just was feeling great. 15k mark. It was meant to be 5k warm up, 4x4 at marathon pace, 1k float, 5k cool down. Got to like 19, and I thought, I fucking hate running. I was so over it, and I was tired. And then like the 22k mark, I think I bonked. I think that's what bonking is.
You bonked?
Yeah, I was running and going, why?
You had some gut troubles
I'm just going, why can't I run any quicker? I'm just plodding along. I'm eating Morton. I'm going, this is insane. I'm going to have to camp out here and die. And I just felt so bad. And then I held like a 5:40 pace at the end, but that was my low. And I was really tired today at work and tired last night. And I had a shitty sleep because I ran so late. But anyway, that was that. The high.
You already said high.
What was the high? Oh, the 6 hours of podcasting. Yeah. Does it sound like I'm talking really quick? I feel like I'm on the high right now on podcasts, off fumes. But anyway, and then the other The other high was...
Why do you have to do 2?
Oh, sweet. That's it. I don't know how many other high.
Yeah, you're only allowed 1 high a week.
Yeah, true. Yeah, that's true. Only 1 high, but I'm allowed lots of lows. That's the main thing. I can feel bad heaps, but only good ones. No, actually, what about one of the highs was Ian saying he loves listening to our bickering and banter.
Oh, yeah, that was cool.
He was saying, and for people listening to this, like, Kelly and I, when we very first started, it probably sounded like it was a bit of not banter, like we hated each other. But Ian was like, yeah, it's funny. What I love is you wouldn't be able to talk like that with a co-host, but because you're like partners, you can kind of talk to each other like that. And, I can tell you off and you still love me, I hope.
So I can bash you.
Yeah, but it was like just good banter, which is true. So if you're listening to this and we do sound, and it's usually me because that's my personality, I sound like I don't know what you would say, like boisterous, or we're bickering.
It's because you're so loud.
Yeah, and talk quick. What's that thing? It's like talk quick. I can't remember. But anyway, that's a bit like that. So we end it there. We've been talking for 10 minutes. Cool. So enjoy part 1. Ian Griffiths. Enjoy.
Griffiths.
Yeah. Have a lovely week, guys. Lovely. All right. Welcome back, Sports Medicine Project people, to another episode. Now, very special guest, and I'm going to tell a little bit of a story a little bit later on, but I'm going to introduce our lovely guest, Ian Griffiths. Mate, how you going?
I'm well. Thanks for having me, both of you. I want to know what this story is. I don't think I can wait till later. What's going on?
All right. I'll set the scene. So I'm going to set the scene for our lovely listeners there. And I know it's a lot of younger clinicians and students, which I wasn't too long ago, but I've just left university. So over here, it's Christmas to like February where we get our registration. So we're in lull. So we're not allowed to practice, but we're about to start work. And I've just left uni, really loving biomechanics and sports podiatry. I was a big believer in, pronation is the cause of all injury, overpronation, not an understanding of the complexity of pain and injury. And I actually found your page and heard about you in that break and started listening to some of your content, a bit of Pod Chat Live, some of your Instagram, and I thought, wow, this is really different to anything that I've heard, but it makes a lot of sense. And then from there, it was kind of the start of my journey, I guess, as a well-rounded podiatrist. So you were what I would call the first modern podiatrist that I ever heard of, where, yes, biomechanics matter, but in the sense of, the sum of the parts is greater than the whole. So I've got to thank you for that.
Thank you. It's really kind. I like hearing the word modern because it makes me feel less old than I actually am. So that's delightful to hear.
The modern and young podiatrist, and the Michael Jordan of podiatry in my eyes.
Definitely not, but no, thank you. That's really kind. It's good to know that someone out there is reading and listening as well, right?
Yeah, I'm that one.
Yeah, I'll take it.
Yeah, so we'll get cracking, but I just wanted to ask, whereabouts are you at the moment?
Right now, I'm in my front room, which is in Hertfordshire in England. It's just about an hour north of London in England. I don't know if you guys have ever been over. But yeah, if we say London, then you got a rough idea of where we are. I was just about
to say, you've almost got to kind of add that on to the end. And when we was talking to other international guests from the UK, they've said, and they'll say, and I go, oh yeah, and I'm kind of nodding going, please say how far that is from London, because that's where I know kind of where it is.
Yeah, no, I'm an hour from London. So I live in Hertfordshire, but I practice in London. So yeah, London's fine.
Yeah. And it's 10 p.m. where you are, hey?
It is, yes, just gone 10 p.m.
That's commitment. Yeah. I'm asleep by like 8:30 every night, so I just can't fathom that.
I know. I said to you just before we came live, I said I was thinking of making up a story that I'd cancelled some really elaborate plans to do this, but I promise you I haven't. This is, I will talk this stuff any time, any day of the week that anyone will have me. So yeah, thanks for having me.
That's passion. 10 p.m. Saturday night, that's what podiatrists should be doing, talking podiatry out in the world to anyone that wants to listen.
Is it passion or is it sad? It's probably somewhere in between, but yeah.
So what got you into podiatry, and tell us your story, Ian?
Yeah, I will. Cut me off. I'm known for being a rambler, so cut me. I'll try and give you the short version. But it wasn't something I particularly grew up wanting to be, or if I'm honest, grew up knowing what it was. And I don't think that's an uncommon thing either, certainly not in the UK. I had my heart set on being a pharmacist. And I don't know if Blake's heard any of my, or Kelly, you may have heard them too. When I go analogies, I go pharmacology analogies a lot.
Yeah.
And I think that's my little throwback to what my original sort of thought process about what my career would be. So I finished my A levels, didn't do great in chemistry, which you could argue is a problem for someone wanting to do pharmacy, and it was. So I didn't get into university. So I went and did like a vocational, like a bit like an apprenticeship, like a diploma, where you work in a pharmacy in a hospital for 4 days a week, and then you go to college 1 day a week, and you do that for 2 years. And you end up with a diploma in pharmaceutical science. So my first ever sort of qualification was in pharmaceutical science, and then I decided I'm going to use that to go to uni to study pharmacy. And when I applied, they said, no, you still need A-level chemistry, which was a problem. So I went to night school deciding, okay, I'm going to just do this. I'm going to knuckle down. I was working all day, and then I went to night school to study chemistry. And day one, I'm sitting there 5 minutes into this 3-hour night school lecture, and I'm like, I don't know if I can do this. I love physics. I love biology. I just can't stand chemistry. And I'm chatting to the chap next to me, who's about my age at this time. We're only now, I don't know, very early 20, I think we were, 1920. 21. And I said, what's your story? And he said, oh, I'm going to study podiatry. Yeah, I said, what's that? I'd never heard of it. And he said, I said, why are you here doing chemistry? Like, do you need chemistry for that? He said, no, I've been out of school. I left school when I was 18, like 3 years ago. And all my university when I'm applying to is to see that I've recently studied something scientific. So evidence of recent study. And this is the only one that basically fits my weekly timetable. And for the next 3 hours, instead of listening to the chemistry lecture at the front, I turned to this chap. I was like, tell me more about this podiatry then. What's the deal? I got a 3-hour pitch. He told me everything about what it is. You can study children, and you can study sports injuries and biomechanics, and you can go on to do podiatric surgery. And I left this 3-hour lecture thinking, well, that's it. Like, I'm going to be one of those. Went home, sent an email and basically to a couple of podiatry schools, telling them what qualifications I had at the time, and they went, "We'll take you tomorrow." So here's the crazy thing: like, I don't know who this guy was. I don't remember his name. I don't know if he went on to study podiatry. We are talking 1999, so we're looking at 20. What's that, coming up 24 years ago? He may well be a podiatrist of 20 years, same as I am now. I don't know if he is. I don't know if he isn't. But this stranger, 3 hours next to him, literally took me from pharmacy, podiatry. Next September I started. Never regretted it a single day since. That's my story.
And
I know, crazy, right?
Like a whole career as well, and presenting at conferences and podcasts and things, all from this one guy. Surely, I mean, hopefully he's a podiatrist, and just one day he's like, just sees your face on this conference and goes, "Oh, I know this guy. I sat next to him 2 years ago."
I've started telling this story recently when people ask me, in the hope that if he is, he'll be like, I'm that. I remember talking to that guy because, he's given me a career that I love. I'm incredibly passionate about it. It gives me as much as I give it. It's allowed me to travel the world. I don't know that pharmacy would have ever done that for me. It's still my first love, but it's like, I guess, it's like your first love at school, and then they're always in your mind, but they don't end up becoming your wife. Like, podiatry is my work wife, but it wasn't my first love. But that's probably a horrible analogy, but you know what I mean.
Yeah, your wife's in the next room going, "What did he just say?"
I know. I should just stick to the pharmacology analogies. I think.
Incredible.
It's funny you say that though, also, because you were tossing between pharmacy.
That's
being a pharmacist or a podiatrist.
Yeah, I actually I did my first uni, and I was enrolled in pharmacy up until 2 weeks until the university, like the semester started, and I was like, I just want to do something a little bit more hands-on. I always had podiatry in my mind, and it was one of my preferences, but I was enrolled in pharmacy, ready to start, and I thought, I want to do something more hands-on, and then end up going into podiatry. Yeah, that's funny.
I think reflecting back now, knowing how much I get to interact with people, and that wouldn't necessarily have been the case, in the world of pharmaceutical science. It's absolutely the right choice for me and my personality, I think.
Yeah, definitely. So we'll get cracking with the very first question, which is probably the funnest question and the one that's probably going to be the most maybe debate over because everyone's got a different answer. But being a podiatrist, knowing all the things you know about shoes, and by judging from your Instagram, you've got about 4,000 shoes. You'd have to have a shoe room in your house. What is your favorite running shoe and why?
Yeah, I do have a shoe room. It's not. It's the study, but it's study / shoe room, and it's contentious in my household because my wife's got me on a 1 in 1 out policy now.
Oh,
So when new shoes, you rolling that method as well. When one pair comes in, I have to either give a pair to a friend or give a pair to charity or throw a pair away. I tend to do one of the former two. So yeah, I think I've got about 70 pairs, something like that. What's my favorite? It varies. It depends on the day. It depends on the weather. It depends on what session I've got planned. But generally speaking, and we've never had more choice, right? You know this. We've just never had much more choice. For me now, the fact that these high stack, high drop, stiff rocker shoes are fashionable and trendy, and mainly for performance reasons, I know. But the fact that they are so readily accessible in every different brand is delightful to me because that really suits my anatomy. It really suits my structural setup, my anatomical deficits. So I love those shoes. So they're all. I'm not a good enough runner to really delineate between one or the other. So I love the New Balance range. Originally, it was the TC, then it was the RC. Now it's the SC or the Super Comp.
Yeah.
I love the Metaspeed range from Asics. I love the Endorphin range from Saucony, the Speed and the Pro, not so much the Shift. So if you listen to all those shoes, what you realize, and you know these shoes well, I know both of you. I've described really similar shoes there. Like they're more similar than they are different, right? Before, when I started running, and I only started on my 40th birthday. I'm 44 now, just for context. So I was late to it. Football, as in soccer and golf were my sports. And then I had a midlife crisis at 40 and switched to running. And I started in the Adidas Boston Boost because 4 years ago, there was no, the shoes I've just mentioned weren't even available. And I loved that Boston Boost. But then once I felt the stiff rocker, the high stack, of the modern shoes that I've just described, I put my Boost on the other day for like old time's sake, and thinking, these are going to feel like an old friend, like a pair of slippers. I went out for just like 6 miles or so. I just hated every step of it. So I know you've spoken to Nitta about this, and Nitta's a good friend of mine, and we talk shoes, we nerd out on shoes, and he was one of the first people that said to me, and it really made me realize it's so true when we talk about what feels comfortable. And I know lots of people place different emphasis on the importance of comfort, but when we talk about generally what's comfortable, what we forget is that changes. That changes. It was different between person, but it's different within person, not just over the same kind of week, but over months and months and months. So I know Nitta's talked about going back to old shoes he used to love, and he just doesn't love them anymore because his comfort filters or his comfort dial has moved based on what he's been wearing in recent months. So it's another reason I try and get my feet into as many shoes as possible, not just to experience them and feel them. And then when patients inevitably say, is that shoe true to size? Does it come up half a size big, or is that rocker aggressive or stiff? I want to know, kind of like, even though how I answer those questions isn't necessarily what they will think, at least it gives me, in my opinion, that rocker is really stiff and aggressive, or in my opinion, that rocker is a bit too distal or a bit too, I like to have that sort of ability to impart first-hand knowledge rather than just what I've read. But also I like to get my feet in as many shoes as possible so I can constantly keep tweaking my own sort of sensitivity dial to these things. Do you want one? Yeah, I think one shoe right now, for example, the one I'd reach for on race day. That's the important thing, right?
That's the only thing.
If I had a race coming up and I look at all the shoes I've got on my rack, what do I reach for? It's the Next Percent vape. It's the Nike Next Percent 2 Vaporfly Next Percent.
Yeah, good shoe.
I don't tend to do many threshold or tempo or interval sessions in it, but I tend to reach for it on race day, mostly because I run in a lot of Nike vests and I like my shoes. I've got borderline. Yeah, I'm particular about things. I like to if I'm wearing Nike top, I like to have Nike on my feet, and if I decide I'm going to wear my, I don't have much Asics kit, so I can't tend to wear my Asics on race day. It just doesn't, just a weird thing about me. But yeah, Next Percent's a race day shoe for sure.
Would that does that change depending on the distance or any distance?
So unlike you guys, I don't go beyond half marathons. So I'm, 5K, 10K half, and I wear it for all. I think it's for me at least, it does the job across all those three. I don't know. Most of my friends that use it for marathons are normally done in about 2:20. So I don't look to them for advice, because the reality is, if I did a marathon, I suspect I'd be on my feet for much closer to 4 hours, and I don't know that the next percent for 4 hours would feel super great on my feet. Then again, I don't think anything would after 4 hours, to be honest.
Yeah.
Actually 2 weeks out from a marathon. Funny you say that.
What are you going? What are you going for? What are you going to put on your feet?
I'm going to wear the Saucony Endorphin Speeds. I think they'll be more comfortable over the 42. Yeah. I agree. I think my feet would be so uncomfortable in the Vaporflies for a marathon. Like them for the half, but no more than that.
Yeah, that's a cracking shoe as well, isn't it?
Yeah,
what are you going to...
I just got a pair of the Vivo Barefoots. No, I'm joking. I just they're coming hopefully tomorrow, the Alpha Fly 2s. I'm going to give them a go.
Alpha Fly, interesting. Do you like the Alpha Fly 1 then, or?
I haven't tried it.
See, I'm not a fan. Controversial. I didn't like it at all.
Oh, don't tell me that, because I thought if Kipchoge can run under 2 hours, surely it'll work for me. We're pretty similar build-ish.
You're almost identical. Yeah, absolutely.
Almost the same. Do you I do want to ask, because I definitely find, and I was talking to Nita about this as well, like, and using carbon plated shoes to have like therapeutic effect in the clinic as well. Do you tend to see any use case for them clinically, and like using them and recommending them to patients for, big toe OA or ankle OA and things like that? And do you think there's any harm in running in them long term? Because you've got a little bit of research to say it, reduces the workload at the first MTP and the calf and things. What do you think?
So to answer the first question of the two there, we absolutely recommend, not necessarily like a Vaporfly clinically, because if someone comes in and they're they've got, I don't know, any kind of forefoot load issues, so we a stiff rocker, it doesn't have to have a carbon plate to come under that definition, but a stiff rocker will do a wonderful job of offloading the forefoot, whether it be first MTPJ OA, second MTPJ synovitis, plantar plate tear, even Morton's neuroma, actually, or intermetatarsal neuroma, I should say. I found that stiff rocker shoes are wonderful, even just walking around at offloading them. But if you don't have a pair, if I see a runner and they have a pair already, we say, okay, instead of just wearing them once a week for sessions, like walk to work in them for a bit, walk to work in them for the next 3, 4, 5 weeks. If someone doesn't have a pair, throwing out over 200 pounds, sorry, I can't do the dollar conversion, but throwing out that kind of money for a therapeutic effect, particularly if they're a non-runner, they're just not going to do it. But we still recommend stiff rocker, so the Asics Glide Ride comes in here at about 80 pounds now. So you sort of say to people, look, this is going to be so much more effective at offloading a sensitive forefoot than orthoses ever would, for example. And orthoses are 300 pounds and a Glide Ride is 80 pounds. And, I say to them, look, this is a great shoe to wear for a few weeks to settle things down. It's not a life sentence. Pop it then back in the wardrobe. And it's there if you need it. Just the same way, you don't take paracetamol every day just in case you get a headache. But if you wake up with a headache, here's my pharmacy analogies again. You wake up with a headache and you pop a couple of paracetamol. Well, if you wake up in the footsore, reach for the Glide Ride that day. So it's a lovely tool. We absolutely use stiff rocker shoes, not necessarily carbon plated, therapeutically now, more so than ever, because they're more available to us than ever. The second part of the question was, do I think there's a possible cost, I think, of wearing carbon, or training and wearing carbon plated shoes? We don't know, as I know this already. We don't know, but it feels there's a couple of things that feel too good to be true, and one is that we know that you can't cheat physics. So if we can successfully wear a shoe and reduce load in location A, then it's a zero-sum game. If we've reduced load in location A, we've increased it in location B, C, or D, or somewhere else. So we might have robbed Peter to pay Paul. So if reducing load somewhere has to put it somewhere else. So I think it's foolish for us to say that might not come at a cost. And the other thing that I can't shake the shake the feeling of, and it is just a feeling, is that I don't think there's any debate now that these shoes improve performance and improve running economy. I don't think it's unreasonable to say we all agree that now. Almost everything I've ever come across that dramatically improves performance, as you dial up things to really, really maximize performance, what you tend to find is that you might, if performance goes up, then so will your injury risk. Now, again, we know if we really, really optimize someone for being really, really low risk of injury, if we think we could achieve that, it's highly likely we'd reduce their chances of having really, really high performance as well. I think it's too good to be true that performance maximization and injury minimization can come from one thing. It feels to me like if you're setting yourself up to be perfectly, if we think about how the best performers in the world, they're constantly treading that line and pushing, walking right up to that boundary. And we know there, greater injury risk comes with all the things we do to maximize our performance. So I don't know for sure, but I feel like it could be the case. And I love the research that's coming out at the moment, but it was all still very, very sort of running economy focused and how do these shoes work focused. And I just don't think we have, because they've only been out 4 or 5 years, right? We just don't have the longitudinal data available to us yet. So it's going to be fun. I mean, let me ask you guys a question. You've just mentioned to me you're both doing a marathon and you're both wearing a shoe with a plate in it, although Kelly's is nylon, not carbon fiber, obviously. But all three of us wear carbon plated shoes. We're all enjoying them because they feel great to run in. They're fun. And, all those things. If research came out tomorrow and said, by the way, these dramatically increase your risk of injury, do you think, would we stop wearing them? I don't know that I would.
I think I would, because I've been notoriously injured in my running career, which has been since I was like 16 years old. I don't think I've had 12 months where I haven't had a niggle. So if I found that out, I would, but that's just based off my injury history, I think. And my reason for running is because I love it, not because I want to perform at a really high level. I just want to be able to run sustainably for as long as I can. So that's my answer. You?
I would still run in them because I really think that, and again, this is all hypothetical, I think you can somehow mitigate the effects with consistent heavy resistance strength training and proper load modification.
But we don't know that either.
I know we don't know that, but that's definitely what I think. But yeah, I'll be in the spare room again tonight. Let's start here. But yeah, I don't think I would. What about yourself?
No, I definitely wouldn't. Absolutely not. Like I say, I've finally found shoes that really suit my anatomy. They're super comfy. They're so much fun to run in. Like I say, the performance benefits from them are almost the smallest reason I wear them, to be honest. I'd still wear them if there was no performance benefits from them. I wear them because I really, really, find they just marry with me so well. And if we run, our risk of running injury if we run is always greater than zero, right? So let's just have fun along this. Let's have fun along the way.
Yeah, and you do look good. And if someone sees you coming in bright shoes, I'm thinking, they reckon I'm the best runner ever. And I always pick up the pace a little bit. Like, if you're wearing those shoes, you got to look like you're quick. And then when they're not looking, I'll just slow it down a bit.
Mate, when you've got those alpha flies on, they won't see you coming; they'll hear you coming.
Yeah, I'm a heavy hitter, Rhapsody.
It's funny what you said earlier about the lack of research out there that sort of can definitively say if carbon plated shoes have a cost to wearing them all the time. And your answer that there probably is a cost of wearing them all the time. It's interesting because everyone that we've had on the podcast with a similar level of expertise, such as Simon Bartold and Nitter, and they've all sort of agreed the same thing. So it's funny how we have these ideas and it makes sense, but we just can't prove it, I guess.
Yeah, I'm glad. After a minute, I thought you were going to say that all those aforementioned experienced guys had a different opinion to me, and I was about to backtrack.
No, I have to say everyone has the same idea. It makes total sense, doesn't it? But it's just not out there where we can definitively say that that's the case.
Yeah, holding on the topic of shoes, I know, and I'm not sure if they're still teaching this in the podiatry program in the UK, but how much do you think the shoe categories hold merit? And we're talking, I guess we could talk in the two categories of in the asymptomatic population and in someone in pain. Do you think flatter or pronated feet benefit from having stability shoes? And, on that, is there still the category of stability, neutral, and cushion, or have kind of moved away from that and we're just back to, kind of tissue stress theory?
Yeah, the categories over here, they still exist in so much that I'm not saying they have strong. They certainly have people who speak out against them. But the reality is, if you go into most running shops over here and you go into most websites to buy a shoe, and it may well be the same in Oz. Correct me if it's not, but you still essentially say, okay, I'm looking at can I see all the neutral shoes on the website, or can I look at all the stability shoes? And you go into the store and the neutral shoes are all there under with the banner, and then the stability. And I think they exist to try and make something easier for the consumer, for the runner, easier for the person, the retailer. If it really comes down to the nuts and bolts of it, and we're going to be scientists about this, and we say, okay, how do we define a stability shoe? I don't think there's massive agreement on that. So if we just use I guess what I'm saying is the shoe categories, I feel like they've never been more blurred as well. So we look at shoes traditionally that would be described as cushioned, and they'd be shoes that had a very thick or very compliant, soft midsole, traditionally EVA, but we've got lots of other foams available now. So we look at the Nike Invincible, and it comes under that definition. It's really thick, it's really compliant, it's really soft, it's super comfy. Anyway, I don't know if you've both run in it. It's no doubt it feels cushioned under your feet, and you look at it on the websites and in retail, and it's described as a cushion shoe, but it behaves quite stably because of its width. So we now look at it and go, well, what is this shoe? Is it a stability shoe? Is it a cushion shoe? Because it's soft, but it behaves in quite a stable manner. So I think we look at the categories as a way of trying to simplify things. But as we always know, we simplify it, but it doesn't mean it's right. And then we're in that big debate of should we do things that are right at the cost of confusing people. So I love the idea, I'm sure you've seen it, of Blaise Dubois and JF Esculio and JFAR a few years ago did something called the Minimalist Index, where it was just for minimal shoes, but essentially, brought up a way to say, how can we define, a scale of what minimalist shoes are from based on their design features. So I wonder whether we're perhaps moving one day towards somewhere where we say, no such thing as neutral, no such thing as stability, but let's take, shoe design feature A, like shoe, stack height. And it's a sliding scale from very high all the way down to very low. Then we take drop, very high to very low. Then we take, forefoot width, very high to very low, toe spring angle, very high. And then basically every single shoe, you just see where does it sit on this scale, on this spectrum, for each given feature. And then there really comes a time for me where I don't, I've described the shoes that I like, but I haven't described them as neutral or stability. I've described them with regards to the stack and the drop and the rocker that I like. And if we can then tailor what features we think people like or need, depending on whether they're symptomatic or not, then you can say, okay, I think you need a wide forefoot. I think you need a high drop because you've got a previous history of calf problems. You say to us that you rate cushioning as an important thing to you. That we look at those three things. We look at what shoe sort of ticks all those boxes. So it's more long-winded, more complicated, but I think it's probably the way that we all when we're having chats with patients in clinic and they say, what shoe do you think I need? Because we've got the time and we've had the chance to delve into their history and we get to assess them. We can say, I think you might do well with shoes that have these kind of features. Now in the store, I don't know that would work, but I think we need to move away from categories and move into more sort of that method if we can. Your question about sort of pronated feet and stability shoes, it's a tricky one because we all, I'm sure, I speak for all of us, forgive me if, the royal we were all taught pronated feet need to go in stability shoes. I was taught that for sure. It sounds like you were, Blake. Certainly, I don't know what physio training is like, Kelly, but you're nodding. So I'm guessing you were given something along those lines. So pronated feet go in stability shoes. And then, as you've already said, we get to the point where is pronation, actually something we should be that concerned about? And actually, do pronated feet, are they predictive of injury or pain or and we know that the answer is certainly not particularly clear, and we certainly don't think they're as evil as we once did. And then we moved away from that, and then we had all those NAPIC military studies that looked at sort of took a group of people and said, right, you've got pronated feet, and let's see, we're going to give you stability shoes, but you've got pronated feet, and we're just going to give you shoe at random. And no injury differences between the two groups whatsoever. I've horribly summarized a really massive piece of work there, of course. So we're like, okay, pronation doesn't matter. And then Laurent Malassu and his team in Luxembourg, who I think had done some of the best research recently in recent years and continue to, then they published a review that showed that pronated feet do better in stability shoes. It lowers the risk of injury. So you're like, okay, so now we just, I think it's a bit like whether we should call a tendinopathy a tendinitis, a tendinopathy. We keep changing our mind. It's a bit like that. The honest answer is I don't know where we're at the moment. If someone comes into my clinic with what we would call pronated feet, by whatever definition you use, and they're new to running, and they say, what shoe should I have? Do I need a stability shoe? I'm like, yeah, maybe. I don't know. But here's the thing. You're new to running, so we know that there are other risk factors that are probably bigger. So why don't we focus on the big wins or the big pebbles or whatever, and then let's find a shoe that we think suits some of your foot, architecture characteristics, and then we'll monitor. And it's highly likely that shoe recommendation may change over time, should change over time as you evolve as a runner. If someone comes in with a sore tibialis posterior, then a stability shoe, as if we define it as something with a slightly stiffer medial midsole, it's reasonable to assume that might offload a sore tib post by its generation of external supination moment. So it's not a life sentence. It's not saying you need a stability shoe. It's like, while your tib post sore, throw on a stability shoe for a few weeks or a few months, and then see how you go. So, they have a role, but I just wish I had a better answer. But whether someone's in pain or not, whether the categories continue to exist or not, we're really in a position where we still don't have all the answers, and we've got to make decisions based on just good clinical reasoning, and we still might be wrong.
That's a good answer. I like it.
I did want to go back and kind of just repeat what you said, because I think it's really good, and it's definitely how I treat as well. I know a lot of students listen to this, and it's something that I talk about a lot with the students at the uni is, when you're talking about footwear with patients, rather than probably prescribing too much off their foot type and their biomechanics, but more using tissue stress theory and thinking what characteristics of a shoe are going to best suit your foot type. And I love that idea of using the scale. So someone with like a tib post on that scale might need something a little bit more stable, whereas someone with a bunion deformity might need a little bit more of a wider forefoot. So rather shoe characteristics and matching that up with what they need, rather than just stability, cushion and neutral.
Yeah, definitely. Agree. Yeah, absolutely.
That was good. And that study that you mentioned as well, I actually based my, with Dr. Benjamin Peterson, he was my honours supervisor, and I based some research off that study. And then recently that Cochrane review come out to say that shoes aren't a risk factor for running related injuries. So it's all over the place, isn't it? Yeah,
it's just not black and white. We'd love it to be. Of course, we'd love it to be. The runners would love it to be. But, just because we want it to be, it doesn't mean it is.
Yeah. Now, one of the most common questions we got, and I put this question in here as well, and we also got it from a lot of listeners. A lot of people want to know, what is the most common pathology you see clinically, and how do you tend to manage it? And is it heel pain?
It's not heel pain. That said, if you said to me, what's the most common foot pathology I see, it is absolutely, yeah. The most common pathology I see on a daily basis is patellofemoral pain, but by
really?
Quite some way. Yeah, wow. Absolutely.
I was not expecting that
either.
Yeah, I mean, probably a couple of reasons for it. Some of it may be environmental and contextual, and I'm sure it is, but I have worked very closely for a number of years with Dr. Brad Neal, Dr. Simon Lack, both physios, but both did their PhDs in patellofemoral pain. And as I'm sure Kelly will know, when you look at the consensus statements from the patellofemoral pain retreats, when you look at the best practice guide that was published in BJSM, and when you look at just a recent paper that was published like 4 days ago, foot orthoses come out incredibly favorably for patellofemoral pain, way more favorably than I think most people, including podiatrists, appreciate. So when I work with, two really good physios, both with, PhDs in patellofemoral pain, it's no surprise that they include me and refer me and get me early, get me involved in these cases very, very early. So I see a lot of patellofemoral pain, and it may well be because of the.
Are you giving them custom foot orthoses or off the shelf?
Normally off the shelf, because all of the data, I should go back, and you're quite right to call me on that. I should go back and say all of the research points really, really favorably to orthoses use, but all of the research done has been done with prefabs or off the shelf devices. So yeah, we tend to just give off the shelf. We don't tend to need to go custom, and they're not normally something that, not necessarily something that are going to be used for a long time anyway. We always say to the people, like, these orthoses are going to be here for a good time, not for a long time. So off the shelf is fine. So yeah, patellofemoral pain, and we tend to treat it very much in keeping with the best practice guides and the clinical guidelines. I don't know if you've seen Brad's paper. It was in JOSPT. I think it was published like 3 days ago. And I haven't quite, even though I've read it because it's so new, I haven't quite committed the title to memory. I think it's called 6 Treatments.
Is that the one that's like cupping, dry needling, stretching?
Yeah. Well, we joke about this, right? But you will be surprised to see it's called 6 Treatments Have Positive Effects at 3 months for people with patellofemoral pain, systematic review with meta-analysis. And the two physios I mentioned, my friends and colleagues, they're both authors on it, along with a couple of other people at the university.
We'll put a link in that to the show notes for people.
And you'll be surprised. I think what might interest people is because I know it can be I don't have a dog in this fight particularly, but manual therapy is mentioned. And I won't say anything more, but I'll just let you read the paper and say, this is really, really well done science. So that's worth a read. So yeah, we treat patellofemoral pain very much in keeping with all of those guidelines. And plantar heel pain, which is, joking aside, the most common foot problem I see, and probably is you as well, I'm sure, and probably is for most of us worldwide. We treat that pretty much in keeping with the best practice guide as well, which I was lucky enough to be a member of the team that we published that in the BJSM. Was it 2 years ago? So there's a fairly well structured sort of, and it's not to say that everyone that comes in patellofemoral with a plantar heel pain should be treated in the same way. It's not a recipe book, but it was a systematic review, which was then synthesized alongside interviews with world-leading experts on how they treat it, and also the patient's voice as well. So like a 3-pronged evidence-based tool where we said, what does the research tell us about what works? What do the experts tell us about what they think works? And what do the patients tell us about what's important to them, valuable to them, what they think works, what they think don't? And then we tried to pull all this together and work out what the best thing to do was. And again, orthoses came out reasonably favorably, more so than I thought, if I'm honest. I genuinely...
Is it custom or off the shelf?
It was custom, actually. And I go into all research with a bit of an open mind, as we all should, but we all bring our biases. We can't, switch off the fact we're human. And I must confess, I just didn't think orthoses were going to come out as strongly as they did. I was quite surprised. And Shockwave, which I know we use, but I don't know how it's used in Australia, but in the UK, it's not uncommon for people to say, okay, I've got heel pain, I'm going to go and see the physio for a bit, I'm going to try some insoles, I'm going to do that for 3 months, 6 months, and at some point down the line, okay, I'm not getting better, let's refer for Shockwave. That's certainly the way it's traditionally used in the UK.
That's how it's done over here, more like chronic when it's not improving.
Yeah. Well, what the guide showed was that actually there's reasonable evidence that Shockwave should be brought in much earlier in the treatment pathway. So we tend to treat in keeping with the best practice guide, which was education, and let's not ever dismiss how important that is. Education, not just on what the issue is and reassurance, but education on load management and things. Education, taping came up really favorably, orthoses, Shockwave, and again, the thing that we, I'm sure you know this, you spend many years doing research. It's a thankless task. You're working all day, then you're sitting in front of your computer at night. No one's getting paid for doing research. If anything, it costs you time, money, energy. you know, you go through peer review. That's a long drawn out process. It finally makes it through peer review. You go, oh, thank goodness. Out it gets there into social media. And then someone on Twitter says, this is bullshit. And you're like, oh, God.
Yeah.
And
You
you
can't
know,
avoid it.
it is what it is. But we had a lot of pushback saying, why wasn't strength mentioned? And the reality is, you know, it's not particularly well referred to in the literature yet. I'm sure that will change, and Henrik Reel is doing a lot of work in that regard. But it doesn't, you know, we've got the Rathliff paper.
Yeah, I was going to say that's the only one, isn't it?
That wasn't included in our systematic review because it wasn't of high enough quality. So, you know, there really isn't as much evidence for it. And, you know, when you and Ellie had Kelly had a little argument earlier, not argument, but, you know, set to where she said, you know, strength load management, we hang our hats on it, but we don't know that it's as magical as we sometimes say. It's the same for plantar heel pain. You know, I'm not saying we don't do it, but the evidence isn't really supportive of it yet. When we spoke to patients, they didn't see it as particularly helpful, valuable. So, you know, we really could only make conclusions based on the data that emerged. And strength training just, you know, we referred it to it in the discussion, but we were just like, look, you know, and we had physios in particular just going, this is ridiculous, like massive piece of work, and you've left out strength training. It's like, we haven't left it out. It isn't there yet. So maybe it will be. Maybe, you know, in a few years someone can redo the systematic review, and maybe we'll have more work. But yeah, I'm not saying we don't include it, but I'm saying it's not in the best practice guide because the science isn't really there to support it.
Yeah, it's interesting though, like, and I'm sure, I mean, seeing plantar heel pain compared to, say, an Achilles or a tib post or a perineal, even giving it strength training in isolation, it typically doesn't respond like tendons and muscles do anyway. So it doesn't seem to be, and again, as you said, the research may change, but it doesn't seem to be the low-hanging fruit to add in. Like, it's not what people are missing. It's more the cuddling and the offloading it tends to do a lot better with earlier on anyway. Not to say it doesn't need strength training later on, but earlier on it seems to be more the cuddling stuff.
I think it depends on what the patient is wanting. Like, if the patient's wanting it, like, is that study based off pain or is it based off function? Because if they're wanting to return to some sort of functional activity, I think that's going to involve some sort of graded return to activity, which kind of